For question 5, if you said A, give vitamin K, you're correct. This patient takes warfarin, which needs to be reversed with vitamin K. Question 6 is leading us into our next topic. For question 6, if you said A, to send stool for C. difficile testing, you are correct. This patient recently received ciprofloxacin, a broad-spectrum antibiotic, and then developed severe watery diarrhea, crampy abdominal pain, and fever, and is hemodynamically unstable. This is very concerning for Clostridioides difficile colitis, which is a complication of broad-spectrum antibiotic use. Before we move on to diarrhea, let's start by defining what diarrhea is. Stool consistency can be graded using the Bristol stool scale, and diarrhea is defined as 3 or more Bristol type 5, 6, or 7 stools per day. Acute diarrhea is for less than 14 days, is more likely to be infectious, diet-related, or medication-related. Chronic diarrhea lasts for more than 30 days and is more likely to be due to a non-infectious cause. When assessing patients with diarrhea, it's important to assess their volume and electrolyte status to determine if they need to be rehydrated, which is ideally done orally with solutions that contain both salt and sugar. It's important to note any fever or other associated symptoms like nausea, vomiting, abdominal pain, bloody stools, and jaundice. Assess for dietary triggers and consider recommending a bland diet to help identify and eliminate triggers. As with our patient, it's important to assess for recent antibiotic use, as that can significantly increase the risk for C. difficile colitis. Stool testing can be helpful, but the sensitivity of one single stool sample for ova and parasites when you suspect a parasitic infection is fairly low. Multiple samples are often needed to get the highest possible yield, so you should have a high pretest suspicion for a parasite or amoebic infection before ordering. Stool culture used to be the mainstay for diagnosis of diarrhea caused by bacterial causes, but new multiplex GI pathogen PCR panels are now more commonly used due to their high sensitivity, large number of identified target pathogens, and relatively quick turnaround time. Imaging is not typically indicated unless the patient is toxic appearing or has signs of peritonitis or obstruction. Colonoscopy can be indicated for chronic diarrhea with alarm features like bloody stool, decreased stool caliber, fevers, and weight loss. This is a highly comprehensive chart of possible causes of diarrhea. Generally, diarrhea can be described as inflammatory, watery, or fatty. Inflammatory diarrhea can be divided into infectious and non-infectious causes. Non-infectious causes can include inflammatory bowel diseases like ulcerative colitis and Crohn's disease. Feel free to pause this to review before moving on. Infectious diarrhea can be inflammatory or secretory, depending on the cause. This chart shows some common testable causes of infectious diarrhea and some of the trigger words you may see in a question that should make you think of them. There are many viral, bacterial, and amoebic causes of diarrhea. Take a moment to pause this video and review some of the key words associated with them, as this may help trigger your memory if you see them on a shelf question. Inflammatory bowel disease includes ulcerative colitis and Crohn's disease, which both present with abdominal pain and diarrhea, which can be bloody, but which do have some distinguishing features between them. Crohn's disease can affect any part of the oropharyngeal and GI tract, from the mouth to the anus, though the rectum is often spared, and is characterized by deep, patchy ulcers with areas of normal mucosa in between them. Ulcerative colitis only affects the colon and rectum, but is usually continuous and circumferential with more superficial ulcers. Both can have extraintestinal manifestations. Crohn's can cause fistulas between the GI tract and other structures or the skin, and is associated with malabsorption, ankylosing spondylitis, and oxalate renal stones. Ulcerative colitis is associated with primary sclerosing cholangitis, pyoderma gangrenosum, ankylosing spondylitis, uveitis, and pleuritis. A history of smoking increases the risk of Crohn's disease, but decreases the risk of ulcerative colitis. Treatment is similar, but the first line for patients with Crohn's disease will be sulfasalazine, whereas for ulcerative colitis it will be mesalamine. Otherwise, both patients are frequently managed with budesonide, short courses of other systemic steroids, and immunomodulators depending on the severity of disease and their response to treatment. Patients with ulcerative colitis may need colectomy for treatment-refractory disease, but because Crohn's can affect the entire GI tract, this is less frequently done for Crohn's disease. Other causes of inflammatory diarrhea can include bowel ischemia, as discussed previously, radiation enteritis, or microscopic colitis. Both osmotic and secretory causes can cause watery diarrhea, and they can be distinguished by two methods. Osmotic diarrhea stops when the patient fasts and has a stool osmotic gap of greater than 100 milliosm. Secretory diarrhea continues when the patient fasts and has a stool osmotic gap less than 50 milliosm. Causes of osmotic diarrhea include lactose intolerance, non-absorbable dietary sugars, and small intestine bacterial overgrowth, In all of these, solutes present in the stool continue to pull water into the lumen, causing watery diarrhea. But when the solute isn't present, the diarrhea stops. Secretory diarrhea can be caused by infections listed 2 slides previously, but can also have non-infectious causes, including systemic mastocytosis and hormone-producing tumors like gastrinoma, glucagonoma, and vipoma. Neuroendocrine tumors causing Cardinal syndrome frequently cause secretory diarrhea as well, in addition to flushing, and the tests used to diagnose this would be urine serotonin or 5-HIAA. Dysmotility disorders in which food moves through the GI tract faster than it should can also cause diarrhea. The most common cause is irritable bowel syndrome, which can present with diarrhea, constipation, or both. This is diagnosed using the Rome criteria, and the hallmark of IBS is that abdominal pain and bloating improve after defecation. Other causes can include medications that can speed up GI motility, thyrotoxicosis, and connective tissue disorders like scleroderma and amyloidosis. Finally, disorders that cause either malabsorption or maldigestion can cause diarrhea. This includes celiac disease, which can be diagnosed with serum tissue transglutaminase, or antigliadin IgA, as well as on histopathology. Pancreatic insufficiency, which is most commonly seen in patients who have a history of chronic pancreatitis or pancreatic resection, can also cause diarrhea. These patients often require supplementation of digestive enzymes. In these patients, fecal elastase levels will be low. Another cause of malabsorptive diarrhea is short gut syndrome, which occurs when patients have had so much of their small bowel removed they cannot adequately absorb nutrients and water from their food. These patients may also require digestive enzyme supplementation, in addition to IV total parenteral nutrition to meet their nutritional needs. Let's try some questions before we move on to another topic.